Hello everyone, I am Dr. Manish Mahajan, Consultant Neurologist at Artemis Agrim Institute of Neurosciences, Artemis Hospital, Gurgaon. Today I am going to discuss acute management of migraine and what's new in the offering. Treating acute migraine is challenging because of substantial rates of non-response to medications and difficulty in predicting individual response to a specific agent or dose. Data comparing different drug classes are relatively scarce. Primary headache disorders are the one where the headache is the disease in itself. Migraine is a common disabling primary headache disorder, being the third highest cause of disability worldwide in both the genders, especially for the young population, as per the Global Burden of Disease Study 2015. The two major forms of migraine are migraine with and without aura. According to the International Classification of Headache Disorders 3, migraine without aura is diagnosed if at least 5 headache attacks, each lasting 4 to 72 hours, either untreated or unsuccessfully treated, have at least two of the following specific features, that is, are unilateral location, have pulsatile quality, are moderate to severe in intensity, are aggravated by routine physical activity, and are associated with either nausea and or vomiting or photophobia and phonophobia. These headaches should also be not better explained by any other cause in the classification. On the other hand, migraine with aura is primarily characterized by the transient focal neurological symptoms called aura that usually precede or sometimes accompany the headache. Visual aura is the most common type of aura, occurring in over 90% of the patients, and these aura should have at least 3 of the following 6 characteristics. At least one aura symptom spreads gradually over more than or equal to 5 minutes. 2 or more aura symptoms occur in succession. Each individual aura symptom lasts 5 to 60 minutes, and in the kids it can be 2 to 60 minutes. At least one aura symptom is unilateral. At least one aura symptom is positive, and the aura is accompanied or followed within 60 minutes by the headache. Some patients also experience a prodrome phase occurring hours or days before the headache and or a postdrome phase following headache resolution. Prodromal and postdromal symptoms include hyperactivity, hypoactivity, depression, cravings for particular foods, repetitive yawning, fatigue and neck stiffness, and or pain. Postdrome syndrome can last for up to 48 hours. A minority of women have attacks of migraine in association with the majority of their menstrual cycles. Most such attacks are without aura. Attacks during menstruation tend to be longer and accompanied by more severe nausea than attacks outside the menstrual cycle. So as depicted in this diagram, the migraine can be perceived as a cycle of recurring headaches with variable inter-attack period and a prominent nociceptive phase of headache. Very frequent migraine attacks are distinguished as chronic migraine, that is defined as headache occurring on more than 15 days per month for consecutive 3 months, and out of these more than 8 headaches have features of migraine. There is an annual transformation of 3.1% from the episodic migraine to chronic migraine. However, there is a natural history consequence in selecting the best acute treatment of migraine, because optimal acute treatment is associated with a reduced risk of progression of episodic migraine to chronic migraine, as highlighted by the American Migraine Prevalence and Prevention Trial of 2015, where using the Migraine Treatment Optimization Questionnaire 4, a significant fold increase rate of transformation was observed across the subgroups of maximal to very poor control optimization of the acute headache management. This emphasizes the role of optimal acute treatment, the topic of today's discussion. A very pertinent fact that is worth mentioning here is the risk of medication overuse. Migraine without aura is the disease most prone to accelerate with frequent use of symptomatic or acute medication. Acute treatment of migraine includes the use of drug therapy and behavioral techniques. Several general principles improve outcomes for acute treatment, including giving acute medication early while pain is mild and choosing the right dose and route of administration. The overall efficacy of acute treatments for migraine can be monitored by validated patient-reported outcome measures. But in real life, it is the headache diary that is the most useful tool. Optimal acute treatment yields both a pain-free response and a sustained pain-free response. The International Headache Society 2012 third edition guidelines for the controlled trials of drugs in migraine has ranked percentage of patients headache-free at 2 hours as the standard. The standard of care for acute therapy is further put at sustained pain-free response, that is one and done, because achieving this result reduces disability, optimally restores the function with minimal adverse events and cost. But there are certain pitfalls to this approach, because most of these patients studied in the clinical trials, had attacks which were moderate or severe in intensity. So the response cannot be replicated in the real life scenarios. And it's a common clinical observation that the acute treatment when used early is better, and when used for less severe attack is better. Two validated patient-reported outcome tools are available for assessment of acute treatment efficacy: the Migraine Assessment of Current Therapy and the Migraine Treatment Optimization Questionnaire, though developed for the clinical trial purposes but can be utilized in routine clinical practice as well. Migraine ACT was a compilation of the 4 top choices from 27 tested in 4 domains, that is, consistency of the response, global assessment of relief, impact, and the emotional response. Each yes response is scored 1. A migraine ACT score of 2 is the score associated with a clinical indication to switch acute medications. Whereas the MTOQ questionnaire can be administered in entirety, that is the 19 items, or in truncated forms MTOQ4 or MTOQ6, both validated. The 4 questions of MTOQ4 are very similar to migraine ACT, confirming the validity of the independent assessments of items for assessment of acute treatment of migraine. So how to select the correct acute treatment? Simple analgesics, though non-specific, are used by most individuals with migraine and have been shown to be effective for mild or moderate pain. Naproxen sodium has a superior safety profile with respect to cardiovascular risk and is an excellent NSAID for acute treatment of migraine. Its combination with sumatriptan showed benefit over the individual components in 2 pivotal modified factorial studies. When contraindications do not exist, triptans are widely considered to be the first-line drugs for patients with migraine attacks associated with moderate or severe pain intensity. Triptans are available in a variety of formulations. This variety allows the patient and the clinician the ability to individualize the mode of administration on the basis of different attack profiles between patients and within the same patient. A combination of acute medications that possess different mechanisms of action could also be of use for patients who do not achieve rapid relief or who have recurrent headache within 24 to 48 hours after initial relief. Dihydroergotamine can be self-administered by nasal spray or subcutaneous or intramuscular injection and can be of use in patients who do not respond to or tolerate triptans. Liquid nasal DHE is currently extremely expensive. Use requires patients to construct and prime a nasal device and administer 4 sprays over 15 minutes without sniffing. Nasal stuffiness, low efficacy, and inconsistency of clinical effect limit its use, in addition to its difficult access owing to cost, although all these have level A evidence. Oral ergotamine tartrate is seldom given to patients because of its poor oral bioavailability, lower efficacy than triptans, and its association with frequent occurrences of nausea, as ketoprofen or other NSAIDs and IV magnesium, who all have level B evidence in the management of acute migraine, similarly to antiemetics and neuroleptics. Little evidence exists for the use of oral or parenteral opioids or butyl containing analgesics for the acute treatment of migraine, and all evidence-based guidelines recommend against their routine use because of the high incidence of adverse events and the risk of habituation, addiction, tolerance, withdrawal symptoms, and medication overuse headache. Selection of acute treatment of migraine requires stratification, that is, matching acute treatment to characteristics of the attack or the patient. A non-oral route of administration, for example nasal spray, injection, suppository, can improve patient outcomes in those who typically are awakened by moderate to severe attacks or whose pain peaks rapidly, that is within 30 minutes, and could also be advisable for those with nausea or vomiting during the premonitory period or early in the course of the attack, along with those who have special situations like status migrainosus where parenteral route is preferred. Again, headache diary is the only tool that provides us with this information. Although stratified care, that is matching attack severity to treatment intensity, has been shown to improve outcomes for acute treatment, some patients can use a step care within attack strategy by first using simple analgesics and only stepping up to a migraine specific medication if the pain progresses. So, as per the Disability in Strategies of Care, that is the DISC study of 2000 by Lipton et al., administering the migraine disability assessment scale showed better outcomes for patients if they had significant migraine related disability and were given a triptan at the beginning rather than stepping through other treatments first. A follow-on pharmacoeconomic study of the DISC data confirmed that stratified care by disability was also more cost effective than step care. This slide shows the MIDAS questionnaire, which can be used in the clinic settings for assessing the migraine related disability. Let's understand how do acute migraine medications work. This busy slide is a synopsis of what all is happening during an attack of migraine. Regional cerebral blood flow imaging shows no changes suggestive of cortical spreading depression during attacks of migraine without aura, although blood flow changes in the brainstem may occur, as may cortical changes secondary to pain activation. This contrasts with the pathognomic spreading oligemia of migraine with aura. Furthermore, it has been suggested that glial waves or other cortical phenomena may be involved in migraine without aura. The messenger molecules nitric oxide, serotonin and calcitonin gene related peptides are involved. Overall, while the disease was previously regarded as primarily vascular, the importance of sensitization of pain pathways and the possibility that the attacks may originate in the CNS have gained increasing attention over the last decades. At the same time, the circuitry of migraine pain, the trigeminal system, and several aspects of its neurotransmission peripherally and in the trigeminal nucleus caudalis, central mesencephalic gray, and thalamus have been recognized. Highly receptor specific acute medications, including 5-HT1B D receptor agonists, that is the triptans, 5-HT1F receptor agonists, and CGRP receptor antagonists, have demonstrated efficacy in the acute management of migraine. Their mechanisms of action provide new insight into migraine mechanisms. Vessels contain serotonin 5-HT1B receptors, whereas the peripheral nerves contain 5-HT1D receptors. Efferent fibers synapse in the trigeminocervical complex, which extends from the trigeminal nucleus caudalis to the dorsal horns of C1 and C2 and contains 5-HT1B, 1D, 1F receptors. Second order neurons project to more rostral brain areas such as the periaqueductal gray and thalamus. Migraine pain is for the most part generated by release of calcitonin gene related peptides CGRP in the dura mater with the resultant vasodilation and neurogenic inflammation. Triptans and ergots are agonists at some serotonin subreceptors. Activation of 5-HT1 receptors prevent the release of CGRP and prevents nociceptive afferents from carrying the signals back to the brainstem for transduction. Agonism at 5-HT1B receptors results in vasoconstriction of blood vessels dilated by CGRP. NSAIDs inhibit neurogenic inflammation and work centrally to reverse central sensitization. DHE appears to be effective in reversing central sensitization, which could explain why it does not appear to induce medication overuse headache. Its clinical utility in reducing headache recurrences and its use as an acute medication option for those withdrawing from overuse of triptans or analgesics. As highlighted earlier, triptans are available in a variety of formulations, allowing both the patient and the clinician the ability to individualize the mode of administration as per different attack profiles. For triptans with multiple formulations, patients have the flexibility to establish which formulation is most appropriate for a given attack. For example, an attack that begins during waking hours and progresses slowly might be treated with an oral tablet, but an attack that awakens a patient from sleep and is already severe might be better treated with a non-oral formulation. Despite the similar target specificity of all triptans, the efficacy and side effect profiles can differ substantially from patient to patient. To achieve a pain-free state at 2 hours, subcutaneous sumatriptan has the lowest number needed to treat. However, most patients prefer oral triptans. Selection of formulation should be on the basis of a combination of the best evidence, patient preference, and sensitivity to side effects, and the characteristics of individual attacks, that is, time to peak intensity, propensity for recurrence. Pain-free rates at 2 hours are highest for elatriptan 40 mg and rizatriptan 10 mg. However, with concomitant propranolol, rizatriptan dose should be reduced to 5 mg. Elatriptan 40 mg and frovatriptan 2.5 mg are associated with the lowest recurrence rates, whereas almotriptan 12.5 mg and naratriptan 2.5 mg are associated with lower incidence of side effects. Rizatriptan, frovatriptan and zolmitriptan might be preferred in patients with severe allergy to sulfonamides because they do not have a sulfa moiety. Overall, based on extensive clinical trial experience and over 25 years of use in clinical practice, the incidence of adverse vascular events is rare when triptans are used appropriately and according to the prescribing guidelines. However, when the vascular safety profile of triptans was analyzed by US FDA reporting system database with a focus on serious and unexpected adverse events, unexpected associations were revealed between triptan use and ischemic cerebrovascular events, aneurysms and artery dissections, and pregnancy-related vascular events. These associations underscore the rationale for the contraindication of triptans in patients with a history of symptomatic peripheral, coronary and cerebrovascular disease and severe hypertension, and the caution that is taken in prescribing them to patients with vascular risk factors. In the absence of vascular risk factors and contraindications, triptans have shown an overall favorable safety profile, and in some European countries and India, they are available without a prescription. Now a word about the non-invasive neuromodulation devices. 3 non-invasive neuromodulation devices are FDA approved for acute treatment of migraine. The external trigeminal neurostimulation, transcutaneous supraorbital neurostimulation, single pulse transcranial stimulation, and the non-invasive vagal nerve stimulation. Out of these, the first 2 have been approved for both acute and prophylaxis of the migraine, whereas the third one has been approved and has been found useful for acute migraine plus episodic and chronic cluster. All 3 approved neuromodulations are classified as having non-significant risk, meaning that they have minimal, no or trivial adverse events of no consequence. The risk benefit because of the absence of side effect shifts, and these devices should therefore be considered for patients with sensitivity to acute medications, multiple acute medication contraindications, overuse of acute medications, or inadequate benefit from standard acute migraine medications. They can be used alone or adjunctively. Many patients want to use them before medications. There are 3 areas of development for acute treatment of migraine in the future: new devices and the formulations of existing medications, new classes of acute migraine drugs, and new non-invasive neuromodulation devices. The 2 new classes of acute migraine medications are the ditans and the gepants. Lesmetritan is a 5-HT1F agonist that primarily works centrally to terminate acute migraine attacks. The 2 are pain-free responses reported in pivotal trials of lesmetritan are similar to triptans at 28% to 38%. 5-HT1F agonist action does not cause vasoconstriction, unlike triptans and ergots, which is an advantage for this new class of acute medication. There are central adverse events of dizziness and drowsiness. The second new class of acute migraine medications is the gepants. These are small molecule CGRP receptor antagonists, and the two are ubrogepant and rimegepant. 2-hour pain freedom is in the range of 20% and they are excellently tolerable. These medications block the CGRP receptor and prevent CGRP induced vasodilation but do not cause vasoconstriction. So far, there have been no significant safety concerns with the liver metabolism of these medications. The education of patients with frequent migraine attacks about the potential benefits of lifestyle changes and the identification of triggers cannot be undermined, and they should also be explained about the risk for medication overuse headache, and it is paramount. The use of simple analgesics, for example, non-steroidal anti-inflammatory drugs, paracetamol, should be minimized to less than 15 days per month, and triptans, ergots or combination analgesics to less than 10 days per month. Let's have a look at the case of a 23-year-old female who presents to the clinic for evaluation of headache. She is currently 14 weeks pregnant and she complains of holocephalic headache for the last 1 week, which is worsening in intensity. There is history of episodic headaches in the past before conception, but those were neither too severe nor prolonged. The current headache is worse at night and causes blurry vision. Her neurological examination is remarkable for bilateral papilledema without any other focal neurological deficit. The sagittal T1 MRI shows filling defect in the superior sagittal sinus, straight sinus and the transverse sinuses. So I have put this case to highlight the fact that all attacks in a known migraine patients should not be considered as just an acute attack of the migraine. Please watch for some red flags in the form of any progressive or thunderclap headache, new onset headache in elderly, gravid or immunosuppressed person, signs such as papilledema, fever or focal neurological deficit, or any change in character and severity in a chronic headache. You may read this beautiful paper on the SNOOP P10 list of red and orange flags in Neurology 2019. The standard of care for acute therapy is sustained pain-free response that reduces disability, optimally restores function with minimal adverse events and cost, and should be able to monitor by validated patient-reported outcome measures. And that's our team of neurospecialists at Artemis Agrim Institute of Neurosciences. Thank you.